Hi, everyone. Thanks for the invitation. Sorry for not being present in person. My name is Stephane. I'm full-time professor at the Department of Psychiatry, University of Montreal. In the next few minutes, I'll be presenting quickly an ongoing neuroimaging study in which we seek to understand the neuromechanisms involved in the therapeutic effects of the avatar therapy. As explained by my colleagues previously, avatar therapy has positive effects on verbal hallucinations, of course, and also depressive symptoms and quality of life. Among all the different reasons that could explain why the therapy has these positive effects, we have reasons to believe that one of the key mechanisms has to do with the fact that the therapy helps patients to better regulate their negative emotions, the negative emotions provoked by their voice. In the brain, certain brain regions, like for instance, the amygdala, become activated when we experience these strong negative emotions, while other brain regions are activated when we try to get a better control over these negative emotions. In the present project, what we propose is to acquire neuroimaging data both before and after the avatar therapy. And one we want to see is, will there be changes in the brain of patients during the intervention? Will there be changes in the emotional brain, as well as in the brain regions involved in emotion regulation? So to do so, what we are currently carrying out is what we call a partial crossover trial. Basically, we aim to recruit 30 healthy controls that will be scanned once. And we want to scan 25 patients before and after the avatar therapy. In a randomized fashion, half of patients will receive directly the avatar therapy, while the other half will first receive 9 weeks of treatment as usual before receiving 9 weeks of avatar therapy. Using these experimental design, we think it will allow us to make sure that our results are not due to a simple passage of time and are directly related to the therapy. What we expect to see is a lack of change in the brain activity of patients during the treatment as usual, and to see changes specifically during the avatar therapy period. So since this is a quite unique study, we consulted 12 people in order to decide what experimental conditions we should be using in the scanner. This is unusual because in most neuroimaging studies, decisions are made by 1 or 2 researchers. Here we consulted patients, clinicians, researchers, ethicists, etc. So basically, after multiple discussions, we decided to retain 3 experimental conditions. The first one is quite simple. Basically, participant is scanned while they're at rest in the scanner. Super simple. Then there's the voices task. So during the voices task, participants are asked to listen to 25-second periods of negative words and neutral words. This is a pre-recorded task, and all the words are recited by the same person for each participant. What is important to mention here is that the negative words, they do correspond to the insults, to the threats that are most frequently heard by patients. And we chose the words based on previous studies from the lab on verbal hallucinations. Then there's the avatar task. So the avatar task is basically patients need to listen to the same list of words, but this time we're making 2 important changes. The first one is that the voice of the person reciting the words is transformed using our VR technology in order to match as much as possible the tone of the voice heard by the patient. So it's individualized. On top of that, we're also displaying in the scanner an image of the avatar that is being created during the first visit at the lab. We're most probably the first lab to scan patient being exposed to their avatar in the scanner. When we look back to studies that have been performed on on the neurocorrelates of verbal hallucination in schizophrenia. There are about 20, 25 studies out there. And what most studies do usually is that they ask participants in the scanner to click on the button, on a certain button when they start hearing the voice, and click on another one when they stop hearing that voice. Neuroscientists have hypothesized that verbal auditory hallucination are caused by normal activity in the brain, in brain regions that are involved in language and audition. We can see a display of these regions right now, language areas such as Broca, Wernicke, and the auditory cortex. So when we look at the studies that have performed in this fashion, we see that these hypotheses, these very broad hypotheses, are mainly confirmed, meaning that indeed when patients are experiencing are hearing voices, the language areas and the auditory cortex tend to be activated. Now, all that being said, I would like to draw your attention to the fact that in these studies, we do not see activation in brain regions involved what we call the emotional brain or the limbic system. And for us, for our lab, this is problematic because obviously, clinically speaking, when patients are hearing voices, most of the time they're experiencing quite negative emotions. So what are the preliminary results from our ongoing neuroimaging study? Well, right now we've been able to scan 15 healthy volunteers, 9 schizophrenia patients with verbal auditory hallucinations have been scanned at baseline before the intervention, and 6 have completed the avatar therapy. We were able to perform analysis, a preliminary analysis on the baseline data. And of course, we started with the avatar task. And what we see, the results that we get are really, really, really promising. What we see is that during the avatar task, there are potent activations in key regions of the emotional brain, such as the amygdala and the medial orbitofrontal cortex. So it seems that by using the approach that we're using, we're able to detect brain activity that previous studies in the field were not able to detect. So this is really promising for the future. And with these results, well, they really set well the table for the future of this study. What we expect in the future is that, of course, clinically speaking, we expect to see patients improve clinically, and we hope to see also a decrease in the activity of the brain regions that we see right now on the slide. So I would like to conclude this talk by mentioning that our lab feels that there's a lack of studies combining functional neuroimaging and psychosocial interventions in psychiatry, and of course would be really open to collaborations in the future on such types of studies. Thank you very, very much for your attention today.
Thank you, everyone. I know it's the last session. I hope everyone still have a bit of energy to listen to our new project. I will present with my doctoral student, Melissa, and the presentation by my colleague, Stephane Bavin, will be on the neurobiology of Avatar for those who follow Avatar after and before and after. So we'll start with Avatar.
Throw trash at them. They're the real piece of trash. Come on, you can do it. Go mess them up. Put them in the hospital. Go ahead. I know you want to. I know you want to do it. Go punch them in the face.
You have no control. You were never any good in school. You're dumb. You have no friends. Nobody loves you. If you disappeared, no one would notice. When was the last time you talked to your mom? Your family probably forgot you exist.
I can't believe you do that in front of your kids. That's disgusting. You should go kill yourself. Do you even have a place on earth? You don't deserve to live. Your kids should go in foster care. They don't need a parent like you. I'm such a bad mother.
Nobody, you're alone. You're sick. You're sick, Stephane. That's why you have. That's why you can't get a job.
We didn't really create what the avatar was saying. It's really from the patient. So imagine that you're living like this every day in your life. That's the kind of patient who comes to the therapy that I will describe today. So very briefly, for those who are less familiar with schizophrenia, we talk a lot today about different profiles and different diagnoses. It's also the case for schizophrenia, many type of profile. But today we'll talk about a positive symptom specifically, which is auditory verbal hallucination. But there's also other symptoms. So it's really a symptoms therapy, not a therapy for schizophrenia in general that I will present today. And the patient needs to have distress and impairment to have the diagnosis. Auditory verbal hallucinations is more common than we think. In children, it may affect up to 13% of children. They report having heard their names and things like that. In adults, it's about the same. About 10% of the population may have heard at some point verbal things, again, their names, a sentence. But it becomes a problem when the hallucination is almost every day, and there's a lot of impairment, that, like I said in the previous sentence. And this afternoon, my colleague told you that it's about 70% of the patients with schizophrenia who have hallucinations, but 40% of them will still have hallucination even when they're taking antipsychotics. So there's a lot of patients with refractory symptoms. So what do we do when we see a patient with schizophrenia? Most of you know that we start by an antipsychotics, and then if it's not working, we're giving another one. And if it's not working, this is not usually what's happening in the clinic. Usually their psychiatrists are using many antipsychotics before using clozapine, but treatment guidelines are saying that after 2 antipsychotics at a regular dose for enough time, we can use clozapine. But if the patient is resisting to clozapine, we have ultra-resistant patients. And then what we can do, maybe we've seen TMS, RTMS this morning, but the effect size seems to be a bit low. ECT may be tried, but there's a lot of relapse. We can try other psychotherapy as CBT. Well, that's what we are using in our lab. But we think there's place for new therapy, like avatar therapy. Every time there's a sign of resistance for auditory verbal hallucinations, we think that avatar therapy may be a good treatment. So what is an avatar therapy for hallucinations? We start, I hope everyone can see the first session is to create an avatar. So if the patient is saying, I'm hearing a demon with horns, long ears, we create an avatar of what he has in mind. Sometimes they have visual hallucinations of the entity or the demon, so it's easier for them to tell us what he looks like. Some of them are saying, I don't know what he looks like, so we create really with the patient the avatar. So that's session 1. In session 2, that's the most difficult one. It's almost like you've seen at the beginning. I ask the patient to write on a sheet of paper all the things that he's hearing, and then I just repeat what he's hearing through the avatar with my voice change. So it's really anxiogenic for the patient. So usually the immersion is not more than 3, 4, maximum 5 minutes. But after that, session 3, opening, we change the dialogue between the patient and the avatar. And many patients are saying at this session That's not how it goes in my head usually. And I'm telling them it's exactly the point. We need to change how you see the person who's talking to you, how you talk to them, change the relationship with your voice. And then we go through another 7 sessions until the patient may feel better. We chose to go to 9 sessions in our pilot trial because I adapted the therapy from the group in London. They were doing 7, but in our pilot trial, patient needed a bit more. So 9 sessions seemed the best way to give the therapy. I will show you now our lab for you to have a better idea of how we deliver the therapy. So I'm on this side, talking to the patient, using the other side of the window. Now we're creating an avatar together. So as you can see, the avatar can move in the 3D environment. So it can be closer to the patient, it can go far away, it can disappear. Even I can change the avatar to what I call a doctor avatar. So it's a white avatar who was created by the company with whom we work. He's more, the patients are saying, now I feel he's like a carer instead of a persecutor that they usually see. So now we're conducting, it's currently undergoing a large single-blind RCT comparing avatar therapy to cognitive behavioral therapy. Both are 9 sessions. We hope to recruit 68 patients in each arm. But before to do this RCT, we published early last year a 1-year randomized trial comparing avatar therapy to cognitive behavioral therapy. And I will show you all the results, not all the main results. Avatar therapy, 40% of them, and we chose to have a cutoff of 20% reduction in hallucination, had a response. Just remember that these patients are coming, most of them are on clozapine. They tried almost everything on the market, I would say. And 40% of them had a good response, 20% of a reduction in their hallucinations. But also a significant result, cognitive behavioral therapy that is not that much used in Quebec. I don't know here, but in Quebec, it's not that much used. 30% of patients had a decrease of 20% of their hallucinations, only with 9 sessions. So our main outcome was to check the decrease in the hallucinations, and we see that you can see here, we had a really large effect size, so more than 1. We were really happy about that. And cognitive behavioral therapy, it's 0.56. It's a bit higher than in the meta-analysis, which is between 0.3 and 0.4. So the patients are really responding well to our CBT. One good thing is that the patients increase their quality of life with a quite large effect size, almost 0.65. And unfortunately, CBT didn't change much the quality of life of the patient. And that's why we chose today to have a big presentation on the quality of life. So now I invite Melissa to give you a talk on the quality of life change in the patient who follow avatar therapy.
Okay, for the next section of the presentation, I'm going to focus mostly on the impact of avatar therapy on quality of life of the patients that followed it. So what is quality of life? According to the World Health Organization, it's an individual's perception of their position in life in the context of the culture and value system in which they live in relation to their goals, expectations, standards, and concerns. This concept is gaining a lot of importance in health sciences. Traditionally, treatments were mostly focused on symptoms reduction, and actually it's still the case today. But yes, this concept is gaining more and more importance, and we are realizing that there is maybe it's more important that the patient is functioning well and that they are happy about their life and the quality of life is great than only symptom reductions. Obviously, this concept is very complex and multifactorial. There's a huge subjective component to it. It's linked to the recovery concept, which is also very vague. Many attempts have been made to measure it objectively, notably with tools standardized like the SF-36, the quality of life scale, etc. However, these scales don't capture the complexity of that concept, which is why we decided to conduct a qualitative analysis to really capture the subjectivity of patients. So we know that avatar therapy is linked to an increase in quality of life. And as we've seen earlier, the quality of life is increasing after therapy, but also continues to increase 3 months after therapy. So we know that, but we don't know the underlying mechanisms of it, which aspect predominates, how the changes really implement into the patient's lives. So the purpose of this qualitative study was really to explore the changes in quality of life of patients who underwent avatar therapy, while taking into account also their subjective perspective. So to do so, we recruited 10 consecutive patients that were randomized into the avatar therapy group in the context of the undergoing clinical trial. Semi-directed interviews were conducted, one before therapy and also 1 3 months after therapy, because the quality of life was at its highest. Also, each interview was recorded and then transcribed and then was split by ideas. So I will be referring to verbatims. You will see some examples of it later, but basically one verbatim is one idea that is expressed by the patient. So after that, we did a qualitative content analysis in an inductive method that led to themes identification. So we analyzed each case separately, and then we made a theme grid that we corrected in a back and forth process. For each verbatim, each one was coded by at least 2 people, and each disagreement was discussed in a group format with a researcher and students. Themes that were considered irrelevant regarding quality of life or that were very rare were excluded, but basically all the transcription, everything was coded. So after that, we analyzed the variation in the frequency of these themes. So basically what we did is that we, for this analysis that I'm going to present, only the verbatims that were non-directed were included. That is that if the evaluator suggested the answer or the patient only answered by yes or no, these were not included. The idea had to come from the patient. And also only the verbatims that were referring to recent or present ideas were kept. So if the patient was talking about something that happened 10 years ago, we did not keep it. So we measured the variation in the frequency prior to therapy versus after therapy. So a score was calculated for each participant. That is 1 if it increased before versus after, -1 if it decreased, and 0 if it stayed equal. And after that, the variation score was calculated for each team. So it's the sum of the scores of the 10 participants. So if you followed, it goes from -10 to 10. And so in doing our content analysis, we identified 8 main themes. However, these were separated in much more specific sub-themes that I'm not going to all present today. But the main themes were identity, occupations, lifestyle, wishes, interpersonal relationships, psychiatric symptomatology, life events, and the behaviors and attitudes during the interview. So for time purposes, I'm only going to present the main results and their variation scores that are associated. So regarding the psychiatric symptoms, as we've seen, it's the main target of therapy. Many patients observed, actually most patients observed improvement of their psychotic symptoms. So they named it that they improved. Also, there were more positive feelings about their symptoms. They were either improving or becoming positive, where yes, before they were negative. The voice content specifically was less negative. The patients also had less negative relationships with their voices. And also there was less omnipotence beliefs. Also surprising results, but most patients had less delusions, or at least they talked less about it, mostly grandiosity, persecutions, and others. Symptoms had also less impacts on quality of life, especially social behaviors and also activities. Regarding their identities, patients use a lot more self-appraisal at the post-therapy interview versus before. So they were more confident in themselves probably. And they also talked more about their skills. Regarding occupations, they had more hobbies and they were also participating in more daily tasks or course. They had not only they had more projects, but also they had taken more steps into achieving them. For example, if I want to do sports, I took a gym membership, so I took a step into doing it. As for interpersonal relationship, they had less negative relationships, but also the relative have seen improvement in their mental health. Regarding lifestyle, also surprising result, but they seem to have less substance consumption or addictive behaviors. Mostly, some of them had gambling problems or they were taking alcohol or stuff like that. So they described less of it. Also, they had a better perception of their physical health. For example, they described that they slept better. They had a better mood and less insatisfactions regarding their housing situation. So about avatar therapy specifically, 10 out of 10 affirmed that they enjoyed therapy, so all of them. I'm just going to give you a few examples of verbatims. The first one is, I told all my symptoms, then I was not judged, I was not stigmatized. They listened to me, then they tried to give me the possible solutions. I enjoyed it. And another patient said, it was very interesting, very innovative, very well organized. The team, it was a really good team. Also, most of them, 9 out of 10 said directly that the therapy helped them. For example, it gave me a lot of tools to be able to strategize around voices and around visual hallucinations. Another one said, I'll tell you frankly, madame, therapy has brought me a lot. The doctor's behaviors, the way I was accepted with them, it made me feel secure. It helped me cross the springboard, like crossing over to the other side. Another one said that, yes, it had an impact on their gambling problem. Also, two participants mentioned that the therapy helped them reinforce prior achievements. For example, I still managed to accept that and not stop doing things because the voices are against it. It was almost always there before, but it's something that improved a lot more with therapy. Also, the therapy, as we talked about earlier, the first few sessions might be anxiogenic. There are some patients that experience some difficulties with therapy. I'll show you some examples. For example, one patient had a hard time explaining himself. He said, I didn't dare. I find it difficult to talk about my problems. Another patient said that the avatar, the thing with virtual reality, I found that more or less convincing, which is very interesting because this patient had a really good response. So in conclusion, avatar therapy really seems to have a significant and lasting impact on quality of life of patients on several aspects. Mostly, it has an impact of symptoms, which is the main target, but also on hobbies, occupations, personal projects, interpersonal relationships, self-perceptions, mood, perception of treatment, and illness, and also secondary objectives that are specific to each patient, for example, some addictive behaviors and stuff like that. These changes seem to be explained by, yes, an improvement of symptoms, but also they seem to be a change in their perspective of life and personal problems, and also they seem to accept themselves more. So for the next part, it's going.